Today we'll study about anatomy of scalp. This scalp is a soft tissue covering the cranial vault. So you can see the scalp is present in this vault. This is the base of the skull and this is the vault of the skull. So this scalp, it extends anteriorly from the supraorbital margin. This is the orbit and this is the supraorbital margin. Posteriorly, it extends from this external occipital protuberance and superior nuchal line. You can see in this picture, this is the protuberance with the superior nuchal line. So this is the junction between the head and the neck. So till here, posteriorly, you can see the scalp is present there. And then laterally, the scalp, it extends till the zygomatic arch. So this is the boundary of the scalp. The scalp has the 5 layers. These are skin, connective tissue. The third layer is the aponeurosis or Galea Aponeurotica, epicranial aponeurosis it is also called, with the muscle known as occipitofrontalis muscle. And the fourth layer, loose subaponeurotic tissue. And the last layer is the pericranium. So you can remember scalp with the word in front of the skin, connective tissue, aponeurosis, loose connective tissue, and the pericranium. The skin of the scalp is thick, that is almost in 1 mm in diameter, and it has large number of hair follicles. So we can see lots of hair in our scalp, which is also associated with the sebaceous gland. So you can see the sebaceous glands, they are open into the hair, shaft of the hair. So because of this lots of sebaceous gland, this is the common site of the sebaceous cyst. So when there is an obstruction in this secretion of the sebaceous gland, it gets obstructed and the swells up like a bump, which is known as sebaceous cyst in the hair. And if the hair follicles get infected, then there is a problem like folliculitis. So folliculitis and cyst is most common in the scalp area because of the presence of this lots of hair and many glands. The second layer is known as connective tissue. It is also known as superficial fascia. It is thick and dense. It connects the skin with the aponeurosis. So in this picture you can see this is the first layer skin and this is the third layer, Galea Aponeurotica. So the thick connective tissue, it connects this first layer with the third layer. And some peculiarities of this second layer is that it has number of fibrous septa, because of which it is divided into numerous small pockets. And in this pocket there is presence of the blood vessel, veins and the nerve. So in this what you can see is that there is a fibrous septa extending from the aponeurosis to the skin, and in between them the artery, nerves and the veins are present in between this fibrous septa. The clinical anatomy in this second layer is that if there is a wound, cut injury in the scalp, then it bleeds profusely. The reason behind that is these blood vessels, they are prevented from retraction. As there is a presence of numerous fibrous septa in the wall of blood vessel, these fibrous septa, they are supporting the wall of artery and vein. So when there is a cut in this artery, it starts bleeding. So to stop the bleeding, we have to apply the firm pressure by a tight cotton bandage. In this picture you can see the bleeding is stopped by applying the cotton bandage to the cut area. And in second layer, the advantage is that as there is lots of artery, veins, this scalp wound, it heals quickly too. Because you can see there is lots of blood vessels present in this second layer. Now coming to the third layer, that is aponeurosis, or it is also known as epicranial aponeurosis. This aponeurosis is broad, strong and tendinous sheath. So it is, you can see it's a very broad and it is very strong as it joins the two muscles, frontalis and occipitalis. And there is presence of this collagen fibers, type 1 collagen fibers in much amount, and it forms the very strong band. So in each side you can see this aponeurosis, it gets attached to the superior temporal line. So laterally, right lateral and left lateral, it is attached here. So some details about this occipitofrontalis muscle. The occipitalis muscle, it arises from the lateral 2/3 of the superior nuchal line and little from the mastoid process. So this occipitalis muscle, which is present behind, it arises from the superior nuchal line and it extends towards the mastoid process. And the function of this occipitalis muscle is that when it contracts, it retracts the scalp. And this frontalis muscle, it is attached to the skin and superficial fascia of the eyebrow. So there is no any bony attachment of this frontalis muscle. You can see it is attached, some fibers are attached to the skin, that is in the superior part, whereas in the inferior fibers they are attached to this muscle known as orbicularis oculi. The nerve supply of this frontalis muscle is by the temporal branch of the facial nerve. This is the motor nerve that is given to the frontalis muscle. And the function of this frontalis muscle is that when it contracts, it elevates the eyebrow and there is formation of the wrinkles in the forehead. So this horizontal wrinkle, it is present because of this contraction of this muscle. So in this third layer, the clinical anatomy is that there is a gaping of the wound if there is deep cut in the this layer. That is the third layer. The when you see the Galea Aponeurotica, it is running longitudinally. So in this tendon, if you find any transversely, if the wound is present, then because of the pull of the frontalis muscle and occipitalis muscle, the wounds, there is a gap. So to prevent the bleeding from this gap, we have to apply the suture and then the bleeding is stopped. The fourth layer is the loose areolar tissue. This areolar tissue, it is very loose and it connects the epicranial aponeurosis to the periosteum of the skull. So this is the space. This is the fourth layer and it is a potential space. And it connects this upper green color aponeurosis to the pericranium of the skull. You can see this loose areolar tissue, it extends up to this eyelid anteriorly and posteriorly it extends up to this external occipital protuberance. So this is the space. And above this layer, this is known as scalp proper. So these three layers, skin, dense connective tissue, and the Galea Aponeurotica, it works as a single unit. And this is known as surgical layer of the scalp. So there is a gap present in this. Potential gap is there. The fourth layer is also known as dangerous layer of the scalp. It is so called the dangerous layer because there is a presence of this emissary vein. These veins, they are valveless and they connect extracranial veins of the scalp to the intracranial venous sinuses, that is the dural venous sinuses. So this emissary vein, they act as a pathway for the spread of infection from the scalp to the intracranial space. In this picture, you can see this is the dural venous sinuses of the brain. From here, this emissary vein, it passes through the veins of the scalp. So if there is any infection present here, it can pass to the brain area. And these emissary veins, they act as a collateral pathway for the drainage of the venous system, and also it acts as a to equalize the pressure of this intracranial venous sinuses. So in this fourth layer, if there is any blood, collection of the blood due to injury, this blood, they travel down into the eyelid. You can see this in the fourth layer, the blood can travel down to the eyelid because there is no any bony attachment of this fourth layer. And the frontalis muscle, it is attached to the muscle of the eye, that is the orbicularis oculi. So when there is a bleeding, it gravitates down toward the eyelid, and after few hours, the blood can be collected and now seen as a black eye. It is also called as raccoon eye. As the raccoon animal, you can see it has this black color tattoos eye. So it is compared with the raccoon eye. But this collected blood, it cannot pass laterally or posteriorly. This is because you can see there is the attachment of this epicranial aponeurosis and occipitalis muscle to the external occipital protuberance and the superior nuchal line. So below this, the blood does not trickle down. And laterally also, you can see there is an attachment of this epicranial aponeurosis to the superior temporal line. So below this also, blood does not come down. But due to lack of bony attachment anteriorly, the blood, it comes down to the eye and there is a presence of this black eye. Last layer of the scalp is the pericranium. So this pericranium, it is loosely attached to the surface of the bone, but it is very tightly adhered to the suture part. So if this is a frontal parietal bone, then you can see the pericranium is attached very loosely over the surface, but in the border area, it is very tightly adhered. So because of this, And there is a condition known as cephalohematoma. When there is a obstructed labor or during forceps delivery, in the fetus state, you can see there is a blood collected deep to the pericranium. So the swelling takes the shape of the bone, as the pericranium is very loosely attached over the bone, but it is very strongly attached to the sutural line. And then if there is a parietal bone, then you can see it takes the shape of this parietal bone, but it does not shift towards the other bone, as the suture line are strongly attached, and just the bleeding is accumulated below the pericranium. And in this condition, cephalohematoma, it is usually seen in the parietal region, and it is self-resolving. So after 4 to 7 days, it might get resolved. There is another condition known as caput succedaneum. In this condition, you can see there is a swelling, edema in the subcutaneous part over the presenting part of the head during the delivery time because of the obstruction of the venous return. And it usually occurs over the occiput area. In this, you can see there's occiput area and it crosses the suture line. So this is the difference between the caput succedaneum and also the cephalohematoma. When you palpate, the scalp feels very soft, and this edema, it subsides in few days. In this picture, you can see the difference of the caput succedaneum and cephalohematoma. The cephalohematoma, it accumulates just below the pericranium and it takes the shape of the bone, whereas the caput succedaneum, the fluid accumulates below the skin and it does not take the shape of the bone. So that is the difference, and both it gets healed in few days. Now we'll be talking about the arterial supply of the scalp. There is presence of the 5 set of arteries in the scalp area. So in front of the ear, you can see there's a blood supply coming from the supratrochlear and supraorbital artery. These both are the branches from the internal carotid artery, whereas the 3 branches, one is the superficial temporal artery behind the ear lobule, posterior auricular artery behind this, and the occipital artery. These 3 are the branches from the external carotid artery. So there is huge anastomosis between the 2 set of arteries, that is the internal carotid and the external carotid. This superficial temporal artery you can palpate here, just in front of the tragus, and this is the end branch of the external carotid artery. And the venous drainage of the scalp. So the veins are named according to the artery. So there is 2 veins, the supratrochlear and supraorbital vein. They meet at the medial angle of the eye, forming the angular vein, and they continue down as a facial vein. And then posteriorly to this vein, there is a superficial temporal and maxillary vein. Behind the parotid gland, these 2 veins combines and forms a retromandibular vein, which is again divided into anterior and the posterior division. Now what happens is that this anterior division, it joins with the facial vein, forming the common facial vein, and it drains into the internal jugular vein. Whereas the posterior division of the retromandibular vein, it joins with the posterior auricular vein, and finally it drains to the external jugular vein and then to the subclavian vein. Whereas the last vein, occipital vein, it drains into the suboccipital plexus. In this picture, you can see the supratrochlear and the supraorbital vein, it meets at the medial angle of the eye, and then it runs down as a facial vein. And there is a formation of retromandibular vein by the combination of the superficial temporal vein and the maxillary vein. So this is the retromandibular vein. It divides into anterior branch and the posterior branch. You can see the anterior branch, it joins with the facial vein, forming the common facial vein, and it drains into the internal jugular vein. Whereas the posterior division of this retromandibular vein, it joins with the posterior auricular vein, and they combine and drain as a external jugular vein, which again drains into the subclavian vein. Whereas the last vein, that is the occipital vein, it drains into this occipital plexuses. So this is the important venous drainage of the scalp. Lastly, the nerve supply of the scalp. You can see the scalp is supplied from the trigeminal nerve. Sensory nerve is given from the trigeminal nerve. So the name of the nerve is also according to the artery and the vein. The supratrochlear nerve, this is a branch of ophthalmic division of the 5th cranial nerve, that is the trigeminal nerve. And there is the another supraorbital nerve. It is also the branch of ophthalmic division, that is the V1 of the trigeminal nerve. So these all are V1. And the third one is zygomatico-temporal nerve. It is the branch of the V2, that is the maxillary division of the trigeminal nerve. And the auriculotemporal nerve, it is the branch of the mandibular division, that is the V3 of the trigeminal nerve. So from the trigeminal nerve, all the sensory branches are coming and supplying the scalp in front of this ear. So in this picture, you can see the supratrochlear nerve, the supraorbital nerve, zygomatico-temporal nerve, auriculotemporal nerve. These all are the sensory branches in front of the ear lobule. Whereas behind the ear lobule, the sensory nerve supply is coming from the anterior and the posterior rami of this cervical spinal nerves. That is, you can name accordingly greater auricular nerve, lesser occipital nerve, greater occipital nerve, and third occipital nerve. So you can see in this picture behind the ear, there is this greater auricular nerve and the lesser occipital nerve, and greater occipital nerve and the third occipital nerve. Whereas the motor nerve supply of the scalp is only two. One is the temporal branch of the facial nerve, that is the seventh cranial nerve, and another is the posterior auricular branch of the facial nerve. The temporal branch of the facial nerve, it supplies the frontalis muscle. So it acts as a motor supply to the frontalis muscle. When it contracts, you can see there is a wrinkling, and also you can raise the eyebrow. Whereas in this occipitalis muscle, if there is a contraction in this muscle, the scalp retracts backward.